Lovely to see all of you, so many young emergency medicine professionals. As Spiros mentioned, I'm Vincent and I'm going to talk to you about myth-busting. Myth-busting, the art of letting someone know their deeply held beliefs, what they've been practicing the last 20 years, is utter nonsense, and ideally doing so without getting them pissed off at you. Sometimes quite a challenge. No, that's okay. Can we get some help with that, please? That would be lovely. Okay, then I'll just do like this. It's fine. Okay. So, I've prepared an extensive list of my formal qualifications to talk about this topic, as well as my conflicts of interest. In case anyone got any good pharma contacts, please let me know. But as you can see, I'm not the expert on any of the topics I'm going to present to you. So this is not the talk where you're going to walk out of here with the final opinion on things and how to run things. And also, please never change your practice because some random dude at some random conference told you something's great and what you're doing is not great. But please, the goal of this talk is not to be a definitive answer, but rather to provoke some thought, to motivate you and to inspire you to have some discussion. And I really hope we can get some lively discussion going on here, maybe in the break as time is short. I'd like to know who here works at least part-time pre-hospital? Please put your hands up. Yeah, okay, so a third, so not totally irrelevant. Okay. I'd like, as I'm not the expert on any of this, to you guys to do some myth-busting too. I'm gonna ask you for just a couple topics with a let's go, you're a fan, or nah, not really. And if you don't move your hands, I'm gonna assume you don't know. That's fine. So, how's it going with 24-hour observation periods after low voltage electric shock? Who routinely does that? Put your hands up. I see a couple hands up there. Okay, who says no? Yeah, great. I don't need to teach you guys anything. Perfect. I brought this because there's actually a large Danish cohort study that got the debate on this topic started again, where they didn't see any difference in the mortality and cardiac complications compared to the background noise. So if you survive the initial electrocution, your chances of surviving the next day and the next year and the next 10 years are pretty good. Sounds great. How about hypertonic saline for hyponatremia with mild symptoms, such as confusion, a bit of nausea? Who says yes? Hands up. Who says no? Yeah, I see about a third of the room. Okay. I'm going to go with yes. According to the European guidelines by the Societies for Intensive Care Medicine, Nephrology and Endocrinology, hypertonic saline is very safe. The case reports of osmotic myeloanalysis, this is probably over-reported in the literature, the authors argue, and the mortality really stems from the hyponatremia itself mostly. And there might even be some association with osmotic myeloanalysis with severe hyponatremia itself rather than rapid correction, because we correct more rapidly when the hyponatremia tends to be severe. So the authors of the guidelines recommend to at least give a bolus of hypertonic saline in case of any symptoms, even nausea without vomiting and confusion, and also if the hyponatremia is asymptomatic but is started in a less than 24-hour period. So in case any of you guys want to check this out, I highly recommend this literature. How about chest seals for penetrating chest injury? Oh, I may have spoiled you. But the answer is we don't really know. It is widely used and recommended by the Committee on Tactical Combat Casualty Care, but there really are no good studies showing any benefit of chest seals versus nothing, and only of vented chest seals being superior to non-vented chest seals, which seems obvious as non-vented chest seals can cause pneumothorax. So in case any of you guys want to check that out further, there's a systematic review linked up there. Okay, now enough with audience interaction, that gets boring too. I'd like to introduce you guys to a measurement of time, the Ono second. And have you guys heard of the Ono second? It's the second where you realize you have fucked up. excuse my manner of speech, but that horrid feeling that sinks in, and you just know that you've made a huge mistake that can't be easily reverted. I used to do some tech work and ended up missing a semicolon and deleted 1,000 lines of database entries by accident, and it just sinks in. And that's the errors we catch when we talk about error management. When we talk about error management, we talk about a wrong medication being given, the wrong dose, and you're seeing that, and you say, oh no. But I'd argue that these oh no errors are only the tip of the iceberg when it comes to error management. What really lies beneath the water are the never know errors, where you don't even realize that you have made a mistake, because how should you? There's a knowledge gap or other biases that prevent us from knowing that this treatment might be proven to be ineffective in 20 years' time. How could we know? Does that make us bad clinicians? Of course not. We're trying our best. However, it might induce us to be humble and to not place our opinion in the highest regard. And to be skeptical about everything, the things we do and also the things we're not doing yet. Okay, I'd like to go into depth some more about top 3 myths in EM, not because these are the most important or the most relevant, because I like them and I'd like to talk to you about them. So, let's get started. Heparin in non-ST segment elevation ACS. For both of you, where is heparin given pre-hospitally by EMS crews or emergency physicians? Yeah? At least some of the audience put their hands up. That's great. So just to clarify, this is not about STEMI or OMI with ST elevation equivalents. This is about NSTEMI. So when we look at if there's any evidence of the matter, the best we can do is look for a meta-analysis, and there's exactly that on this issue. Heparin versus placebo for NSTEMI, with a large Cochrane meta-analysis with 8 RCTs and about 3,000 patients. This was conducted 2 times, the second round of meta-analysis, and they found no difference in mortality, maybe a decrease in reinfarction rates. However, that stems only from the largest study, and is only apparent when you look at the 4-day outcome. And this difference disappears if you look at the 90 or 160-day outcomes in the study. But of course, increase the risk of bleeding. I don't need to tell you about that. And just a caveat, some of these studies are from the pre-reperfusion era. So I've stolen this fantastic graph from Simon Carley, who many of you probably know. It graphs the diagnostic certainty in blue against the therapeutic benefit in yellow. So as time goes on in the patient journey, our diagnostic accuracy increases, and we're more certain that this patient has a diagnosis. However, for time-critical intervention, the therapeutic benefit decreases. When we find out on autopsy that the patient had a tension pneumothorax, the chest drain will very certainly be right, but it won't benefit the patient. And for heparin in NSTEMI, the curve looks probably more like this, if there is any benefit, and maybe even further down if there's harm. And if there is benefit, the reason we give heparin in ACS after all, if the benefit is there, it is most certainly here, at the cath lab, peri-PCI. That was the reasoning why we started giving heparin to ACS patients in the first place. So, for NSTEMI patients who are going to PCI in 24 hours, there's really no reason to give fast-acting, unfractionated heparin immediately after presentation once you took a look at this ECG. And that is also concurrent with the guideline. The ESC guidelines recommends anticoagulation at the time of diagnosis. However, when is the time of diagnosis for an NSTEMI? It's certainly not when the patient with chest pain walks in, or if you see them pre-hospitally, and not when you look at the ECG. But NSTEMI is diagnosed by troponin. So I'd argue that no chest pain patient without a STEMI or OMI should receive heparin before their troponins are back. And so, thus, I'd argue there's no place for heparin pre-hospitally for everything except STEMI. So let's stop giving it to these types of patients, but also to those patients with low-risk chest pain and angina who'll walk out of there in a couple hours and go home to have a brain bleed. Okay, next up, extrication. Imagine you're going down the road in somewhere in England with your family in your treasured car, and in front of you it's raining, it's England, and in front of you there's a car accident. Just a small wreck, nothing major. You go check it out, put on your vest, important, walk over there, and there's an elderly couple sitting in the car. They're shaken but doing all right, nothing major, and because it's absolutely pouring, you offer to give them shelter in your car until the ambulance and police arrive. And then they sit in the back of your car, you give them some water, they're completely fine. And fire and EMS arrive, and then your car looks something like this. That is a true story of the fire department cutting the roof of a vehicle because the two victims who went there on foot took a seat in there, then reported having some neck tenderness. So this is obviously an extremely exaggerated example. But we do cut a lot of roofs off cars, at least in Germany we do. And we also do extricate a lot of patients on spine boards and with CAT systems still. So there's not great evidence on this. However, the best we have are some experimental studies. It's quite hard to randomize patients this early on in the patient journey. So the experimental data, biomechanic, in the BMJ, they compared 6 different methods of extrication on 16 healthy volunteers. They each got the 6 methods each, and analyzed the C-spine movement in 4 axes. And what we found out, no statistical difference between any of the methods, with the leftmost bar being, hello sir, can you please get out of the car? Okay, thank you. Sounds rather easy compared to a CAT system, which takes 10 minutes maybe, with everything combined. And there also was another study on this where they measured the C-spine movement in a different method, and they compared cutting the roof off, cutting the B-pillar off, doing a crash rescue, so just pulling them and yanking them out of there when whatever means necessary, as if the car was on fire, and again just asking them, hey, could you step out of the car please? And it turns out the self-extrication is even superior in the amount of excursion at the C-spine, and obviously is faster, way faster. So when we look at the most definitive consensus on this topic, there is a Delphi study, also from the UK, by some of the proponents of the EXIT work group who have done great work on this, and they recommend self-extrication or minimally assisted extrication should be standard first-line extrication for all patients without contraindications. Contraindications being a broken pelvis or being unable to understand instructions. And all patients with any evidence of injury should be considered time-dependent and their entrapment time minimized. Because we know that these patients who have evidence of injury and they are entrapped patients have a 2-fold to 3-fold increase in mortality. And these patients are very likely, very high likelihood ratio for serious injury or death. So realistically, for rescue from a vehicle, there are only 2 options. Either self-extrication or crash rescue and get them out of there as fast as possible. There's really no place for what we still often practice, at least in my country, in Germany, this so-called careful extrication with a C-collar and a spine board. Okay, wrapping things up, we're a bit short on time, so I'm gonna have to be concise. I want to talk to you about antiparesis. So in the department where I used to work, at least, where it's pretty common for a patient with pneumonia to walk in and to receive the first shot of paracetamol IV even before they lie down, so to speak. But why do we do that? Fever is evolutionarily conserved from about 0.6 billion years ago, somewhere between innate and adaptive immunity. And it's observed in pretty much every species. Fish swim to warmer waters when they get ill, and they survive better in warmer waters. Bees have fever, they snuggle around more around the hive, and even plants are observed to increase their temperature by up to 2 degrees when they're infected. There's been some studies on this in lizards that actually observe that around 75% of lizards die when kept at their normal temperature, and 75% of lizards survive when they're put in a warmer box as ectotherms. In humans, there is really only bad evidence on this. because it's very hard to put humans in a box and control for temperature. We usually only do that with dead people. There's some observational data on sepsis, where we can see that fever is associated with higher survival and hypothermia with increased mortality. That is likely to be not the fever actually causing the mortality, but the fever being a symptom of a functioning immune response. However, there's also a randomized controlled trial on this. It's critically ill trauma patients in a trauma ICU, where they randomized to fever control from 38.5 degrees on and fever control for 40 degrees and higher. And the trial was stopped early for benefit in mortality. And there's also some data for less severe infections that when you're allowed to have fever and not given antipyretics, that you actually have a shorter time of virus persistency and being able to transmit the virus. And importantly, there's no randomized controlled trial that ever showed any benefit to giving antipyretics in infection. No benefit on mortality, length of symptom duration, etc. So, of course, we can give antipyretics if it helps the patients, if there's discomfort, but we shouldn't give it out of concern for high temperature because the body is never going to harm itself with a physiologic fever. The damage from heat stroke and external high temperature is completely independent of physiologic fever. And so just to wrap things up, when you're in my place as a medical student, I often find myself being the rather junior person in the room and trying to talk to someone about something that I think may have been done wrong. And that oftentimes doesn't go so well if you try it yourself. So over the last years, I've tried to write down what has helped me in starting these difficult conversations and most importantly, get the setting right. The handover in the resource room is probably not the right time to discuss whether a C-spine collar was indicated or not. That can be left up for later. Then voice your perception of things that are going on, and most importantly also voice your concerns. What are you worried about with this patient that's going to happen if whatever you're concerned about is continued? Get an invitation to speak about things and accept if that invitation is not given, and then transfer your knowledge in a short and concise manner, and accept if there's going to be some face-saving emotion, and in the end summarize. So you see, it's not that different from having other difficult conversations. That's it. Thank you very much for your attention, and I hope you walk out of here not thinking that any of this is a definite answer. This is mostly my opinion and my interpretation of things, but walk out of here with some curiosity about things, and I hope that you have some interesting discussions with your colleagues, with each other, and also with me in case of any of you guys want to critique me for things. I'm happy to do so on the break. Thank you guys.